But I'll just start by, and I'll try to watch my language. What the hell are we doing? What are we doing? People who are sick are being punished and languishing. They're not being nourished and given a chance to flourish. People who are sick need access to treatment, need access to tools and to community where they're included. This is Sozosei. It's about creativity. And I'm sorry to say that while there are many, many creative programs and policies, and they need to continue to be developed, it's really about payment reform that will transform the systems. We live in a process, top-down oriented world, not one where the grassroots are driving the grass tops and where we're being paid for outcomes. It boggled my mind when I got to Los Angeles County and I asked my staff why we weren't spending more time engaging people who were not engaged in the system, because in this field, that's about half the problem. And they would say to me, we can't do that. What do you mean we can't do that? It's perhaps the biggest problem, is to engage people who have not been engaged in the system. And when they have been engaged, it's in the back of a police car, or it's being thrown into a hospital, restrained, given shots, and other things which are quite toxic. And the answer to why we can't do that, Dr. Sherin, is because you can't get reimbursed for it. You can't get reimbursed to go in as an assertive community treatment team to a hospital, to debrief with a team in the hospital, talk to them about this individual, to inform them about what's been tried, what works, what doesn't work, to try to help shepherd them out of what's a toxic environment and back into the community because you can't get reimbursed for it? You got to be kidding me. Well, that's the state of affairs, unfortunately. I'd like to just touch on a little bit of history that you probably all have heard many times, but really hearkening back to JFK and the deinstitutionalization movement, which is a beautiful idea, and unfortunately, in most of the world, was not executed properly. JFK was informed by his sister Rosemary, who had her own challenges, ended up getting frontal lobotomy and being institutionalized, warehoused. And he found that completely inhumane and unacceptable. Unfortunately, in this country and much of the Western world, we didn't invest in community and build out community before we had people leave institutional settings. And what do we have now? We have the outdoor asylum of the street and the indoor asylum of the jail. There are some parts of the world, and I point to Trieste, Italy, where a guy named Basaglia, Dr. Basaglia, did something quite different, where community was informed about a different way to deal with and engage and include people with disabilities, where there was a focus on what I call the people, place, and purpose as critical elements alongside treatment. So those systems are set up in a way that a community mental health center will provide treatment. Doesn't mean you have to have an appointment and wait 6 weeks or 3 months to go and see somebody, and then only be given things that are reimbursable. You go because it's a place where you want to go, where you feel welcome, where you have other people who care about you. And if you need to see a clinician, you see him then. And if you want to learn a skill, that skill is provided. There's social enterprise, so you can actually make things and you can make money and you can be connected to other folks. Clearly, we did not do that. I want to show you a quick slide. I don't know if my slide is available. I'm not a big slide guy, but I got one here. Interesting. Colors have changed somehow. But I want to talk about the strategic domains and then a little bit about investment in the future. The green center represents community. And well, what is in community? Well, community, as I was saying, not only does it provide treatment, but it offers lots and lots of prevention-oriented services and opportunities. The social determinants of health are built in. And that's where we want people to be. It's supposed to be surrounded by a yellow ring, which we call the crisis system. Crisis system being urgent cares, emergency departments, hospitals, intensive treatment. So that when someone falls out of the community, they connect with a system of treatment that thoughtfully provides care, brings them back into the community. The problem is that yellow ring is Swiss cheese, and people fall through it every day. And where do they fall? They fall into the institutions, which are appropriately red. And I talked about the institutions, the asyla. That's where people are ending up in the Western world, and it's not slowing down. Los Angeles County, which I just left, probably has about 100,000 people who are homeless, and about 10% of them have a persistent psychotic disorder. About 5,000 of the 20,000 people roughly in jail, again, have a profound and persistent mental illness, a psychotic disorder. What we tried to do, and the reason why I developed this slide and this narrative, is to move folks with those arrows from the institutions and from the crisis system back into the community. And we did a lot of things. One of the things that we did, which I actually did my clinical work with, is street outreach. And I was a psychiatrist sitting on the pavement, talking to people who were sick and trying to get them to understand that there was a potentially different future. One of the things that I did was I took the former director of mental health for the Trieste system out with me to Skid Row, and we sat together. And he looked at me with vacant eyes while we were there, and we went back to my office, and he and his colleagues wept. How can you possibly have this in your country? And what are you going to do? You can't care for people in those settings. In order for us to change this narrative, to reverse the dynamics, we have to reconsider how we spend our money, and we have to reconsider what we're paying for. So we have to pay for outcomes, number one, so that people in the front lines are focused on having someone in a thoughtful, nourishing setting where they have access to all the things they need in life and doing whatever it takes, as we like to say in LA County, heart forward. That's how you get outcomes. That's how you deliver products the way we do in the private sector. Not by just making sausage, getting reimbursed for your sausage, whether anyone wants to eat it and whether it's healthy. So if you look at the lower three diagrams, you'll see what I was trying to sketch out, and there are probably in LA County about 150 different programs within the prevention services. I don't know if you can read that. The social support and the outpatient treatment of the green. Crisis care, again, that's supposed to be yellow, and then the red. And over time, we probably do need to invest in a stronger crisis system because our communities are so inadequate in how they're resourced. We have to have access to intensive treatment to fill in the Swiss cheese and not allow people to fall into our institutions. But over time, it's about a massive investment in community, like they did in Trieste, like JFK called for, and this country and many countries neglected to do. I am, by the way, trying to make up for some time because we're a little behind schedule, but I will say to you that when I got to LA County, I had 3 fundamental priorities. And my first policy priority was to get certification for peers reimbursed through Medicaid. And we did that. It only took 4 tries. And they gutted it in the process, but it's still there and it's going to grow. Why would that be such an important thing? Because that's people. Individuals who are suffering from severe conditions over long periods of time become very isolated. Their families often fracture, unable to maintain relationships, and everybody needs kinship. You need family, you need kinship, you need social support. And real peer work is about lived experience, shared experience, and connecting and being engaged, not in a clinical way. The second thing is housing. As you may see, I'm talking about people, place, and purpose again. And there was a guy in LA County before me named Mitch Katz, who's up in New York now, and he always said, well, I'd prefer to write a prescription for housing than a medication for people because it's more important to their health. I agree with you, Mitch, and I'd say the same thing about peers. And then lastly, of the people, place, and purpose, where is meaningful, purposeful activity in our armamentarium? Where is supported employment? Where are the occupational therapists? These are missing components, and there's a lot of reasons for that, and many of them trace back to what's reimbursable. But a lot of them trace back to the fact that we are not truly recovery-oriented. We don't believe that people who are sick can recover. If we don't believe that, it's not going to happen. And in order for somebody to pursue and achieve people, place, and purpose in their life, they're going to need treatment. They're going to want treatment. So if you get people to want treatment and you present it in a way that is welcoming and not traumatic, there's a new future ahead of us. I have a few slogans that come to mind whenever I'm speaking these days, and I think about them in the context of the mental health tidal wave that we're all going through from these massive global stressors. Obviously, there's COVID. And COVID decimated a lot of the fabric and the connectedness of our populations. There's the post-George Floyd world and the institutional inequities and the structural racism that drives so much of what we're talking about. Social media, which is devastating, I would say all of us, and particularly our younger folks. Climate and climate change and the anxiety that people go through, particularly, again, our younger generations, and particularly in a way that where disparities show up around the world. And wars that are starting to rage around our country. If that set of phenomena does not light us up, I don't know whatever will. We need to get that memo. And we need to recognize, again, that the grassroots must drive the grass tops, that none of us is well until all of us are well. And that's an important thing to say. And it's showing up in really, really profound ways. I would say in communities, on the streets. None of us are well until all of us are well, hands down. And then the last one, the other LOL that I like to talk about, which is the lethality of loneliness. As people become more isolated and more lonely, yes, they are at risk of harming themselves. Yes, they are at more risk of acting out. Yes, they are more likely to suffer health consequences and develop other chronic illnesses and die. And then there's a loss of voice. So it's lethal to the voice of so many amazing, beautiful, smart, talented people when we allow them to become isolated and not have community. I have caught up on time. I'd love to take questions. I think there's I'm just going to take a few minutes, if there are any. If there aren't, I'm just going to exit stage right and hand off my microphone.
No, don't do that. Oh, is this on? Oh. Hello, everybody. My name is Helen Skipper. I am the Executive Director of the New York City Justice Peer Initiative. Thank you for this talk. You talked about people needing treatment and wanting treatment. I just want to posit that the treatment we get has to be culturally responsive. As the Executive Director of the Justice Peer Initiative, I am involved with bringing peer support into the criminal justice system. I also want to posit that you talk very well about peer support. Thank you for that. But we need to look at how peer support that is in the green level, wonderful chart, by the way, wonderful, that is in the green level can also be included in the blue that's supposed to be yellow level.
Nice.
Into the crisis system to help people navigate, negotiate crises, and also prevent crises. And then we also should be in that definite red section, which is re-entry programs in institutions. So if we incorporate and infuse peer support in these three, what we will have is that green section will be fleshed out 200%, and everything else will minimize down to 10%, which is at a good level because we do need these practices. We just don't need as much of them, and they need to be culturally responsive, which also brings us back to Antonia Hilton and talking about Crownsville, how people who get each other because we come from the same community, because we come from the same culture in the behavioral health workforce, which is not really fleshed out. I need somebody, if you're going to treat me, I need somebody who gets me, who not just knows about my diagnosis, but also knows about who I am and where I come from and how I was raised. I just want to throw that out. Thank you.
Yeah, just real quick response. I couldn't agree with you more. If you can imagine that there are green tentacles going into what's red but should be yellow, blue but should be yellow in the red, that's a big part of the problem. All of those street engagement teams in the street and the ones in the jail, those aren't reimbursable either, and in the hospitals and in the emergency departments need peers. We wanted peers in every emergency department in LA County, but for reasons that I shall not go into, we were unable to accomplish that. I hope it gets accomplished. But amen to everything you said. And that's really core to the whole issue of competency, that lived experience, which is why I made it my top policy priority. And it's one of the things that we accomplished in LA County that I'm most proud of.
Thank you.
You can't see me because I'm behind a pole, but hi there.
Okay, last question.
So,
hi.
Hi, somewhere over there. I'm joining y'all today from Rhode Island, and the work that I do there, the work I'm doing there at the moment, is so responsive to what everybody has been talking about today thus far, in the sense of, I work for a social service organization that does housing and employment and has a soup kitchen and is primarily run by people with lived experience of substance use disorder, incarceration, and homelessness. And we're trying to build a healthcare program there so that folks who are already comfortable being there can get their healthcare and behavioral health care where they're already feel in community. And I'm sort of a new healthcare administrator, and I have just sort of every day so demoralized around this reimbursement issue that you talked about so well. And you know, as I think about how we are going to move to this like value-based care kind of model where we're trying to talk about our outcomes, it still all comes down to trying to make this point about how we're saving payers money. And there's just nothing more depressing to me than that, to be in this position constantly of trying to convince people that the amazing work that I'm doing is going to save them money, because I don't actually believe it is. I believe that people are expensive and caring for people is expensive, and that should be okay. And so my question is, like, as we're all trying to figure out how to navigate this evolving sort of payment structure, is there any way out of that like ROI argument, or are we just kind of stuck?
I'll keep it real simple. I mean, first of all, I don't agree that it's going to cost more. I think money is not our biggest challenge. It's the way that money is spent. It's spent on processes, not spent on outcomes. One of the things that's missing from this diagram is that if you look at the bottom above client flow, there's infrastructure. That thing should grow. Those lines should be thicker. And I do believe that whether you want to call it value-based care or whatever, we have to move in the direction of outcomes. I mean, we've dumped billions and billions and billions of dollars into the homeless problem in the state of California, and there's more homeless people. I am going to exit. It's really lovely to see you all. Thank you.